comes back with an arterial sheath, they did not do anything. Maybe there's a spasm for stymie or whatever. Nothing has been done. So no heparin was used. And the cath lab nurse will tell you, you can pull the sheath anytime. Be sure that you do that only when you're ready though. Even if they tell me you can pull it anytime now, no. I got to be ready. This is not an easy job to do. You got to have full needs, you know, all the things that you need are all there. Okay? So no heparin, you can pull anytime once you're ready. And again, follow. You can loosen the clamp after 10 minutes, and then the gradual releases will be every 5 minutes until it comes out, dressing and everything. And if bleeding, the same maneuver. Okay, so complication of this procedure is bleeding. So you poke a site, you poke an artery. You did not poke a vein, you poke an artery here. So here we go, complications, bleeding. If it is mild bleeding, you can actually just use manual pressure using your hand with all its firm fingers. Okay, manual. If you think it is severe and there's hematoma, you're better off with your, if it is the radial, your hand with its knuckles, or 2 hands with their knuckles on the groin. And for the groin, with the hands, both hands has to be utilized. Pressing well, using your gloves, and then thick dressing to push, you know, to compress the site. Okay. You're wondering that after you did the procedure, you notice there's swelling. How come this groin is swelling? Everything's okay. So now you say, oh, I'm bleeding. Okay. So you did all you can, but you still have normal sealing. Normal sealing, we usually give this overnight. We don't usually cap the 12. You all leave that one just in case. Okay. So now you notice it's getting bigger in spite all your maneuvers, everything. So this time you have to do a stat group screen. You have to do stat hemoglobin. These are ways all, you know, on the protocol of the hospital, you know, how much you can do. And so you'll be doing stat blood works now. And the blood came back that it's low. So it's on the low side. And you notice a pressure a little bit on the low side. But the groin keeps going bigger. And you suspect that, oh, it could be pseudoaneurysm. So you speak to the doctor, and they will ask for, you know, they will do an emergent ultrasound, and found the patient has pseudoaneurysm. Pseudoaneurysm here is actually the break of all the layers of the femoral artery. Okay, here. So this is the lumen of the artery, and these are all the layers. So you notice that the blood escapes from the lumen outside to the tissue. Okay, and what happened is that when they treat this one, they normally, the patient will go for ultrasound, and they go to the interventional radiology, and they will actually inject a thrombin, which is it is a coagulant here, and eventually the body will absorb this very slowly. So they will this will coagulate. Okay, so that's pseudoaneurysm. Now there is a bleeding that you don't see. There's no blood coming out from the poke site. There is no swelling, but the patient's blood pressure suddenly dropped to the 70s. Okay, so you got a problem in here, but your heart rate is still good. It's coping. So the heart rate is compensating for low blood pressure. Now you're bolusing the patient with normal saline. What's the problem? So you used already about 1 liter or 2 liters bag of normal saline, and still the blood pressure is low. So now you have to talk to the doctor stat and what's happening. So again, we did all the stat blood works, grouping screen, hemoglobin came back to be 60. In Canada, we are using grams per liter here as a unit for the blood works, and that's too low because the patient originally has a hemoglobin as 150. Suddenly you have 60s. Okay, so blood came back. We do stat transfusion, and while having transfusion, the patient has to go downstairs to have an emergent CT scan. And they found the patient has retroperitoneal bleed. Okay, so retroperitoneal bleed. So that is the RPB. So this is the retroperitoneal space here. If you notice this one here, you have a peritoneum. That is your peritoneum. And you have your retroperitoneal space here. And that is your vertebra. So your retroperitoneal space or retroperitoneum is between your peritoneum and your vertebrae. Okay, and it will accommodate 4 liters maximum of blood in here. So the patient accumulated close to 4 liters of blood, but we have transfusions. So let's say she will consume 3 units of blood, and the following, after 2 units, repeat blood work will show from 68 it went up to 95, 96. After the other blood, it went up to like 110. So we're happy with that. Okay, we all know that the hemoglobin carries the oxygen and everything. We need that. So it's very important that our hemoglobin count is okay. So now vasovagal is another complication that we're dealing with. So we deal with bleeding, the mild, the severe, the pseudoaneurysm, the retroperitoneal bleed, and the ordinary bleeding, no aneurysm, no nothing, but still we deal with that. Okay, so here vasovagal is another problem here. Vasovagal could either be your blood pressure is low, but the heart rate is okay. That's fine. So at least the heart rate is compensating for low pressure, but we have to have the normal saline going. If the blood pressure is 70s, well, it's not good, and the heart rate is, the heart rate is about 90s, then fluid. You just go with fluid here. Okay. Then suddenly, what if your blood pressure is low in the 70s? Now your heart rate now is going down. So then the patient complains, I'm dizzy, decreasing LOC. So now you have here a vasovagal reaction. So what you gotta do? Act quick. Normal saline continues, bolusing continues, get your atropine sulfate. So your atropine sulfate usually is 0.5 milligram. Again, these are all in the orders. You don't decide your medication. You have to act on the doctor's order, on the protocol, on the policy of the hospital, okay? You're not going to decide for yourself. We are RNs, so we have to follow those rules, okay? So follow the PRN. We have PRN orders for bradycardias, and for sedatives and everything, narcotic, we have PRN orders. Okay, so we deal with that, and the pain, the reason the pain cause, complaints of vasovagal reaction is this actually happens during clamp application. What happens when you have clamp application here? When you have clamp application, you're actually compressing 3 organs right there. So you got the nerve, you got the vein, you got the artery. But the pain is the one that's causing the vasovagal reaction here. So you give those things, everything will be okay. But usually, as the clamp, you ease up a little bit with your clamp. Maybe it's too deep a little bit. So you ease up a little bit and the patient will feel a lot better. Okay, so why do we experience this vasovagal reaction? Because we have a paradoxical response here, or paradoxical, yeah, that's right, paradoxical response. What's happened is that I shortcut this one because we have a longer explanation. I got it there. So what happened is that you got here a sympathetic response withdrawal, but you have a vagal response activated. So that's what's going to happen with paradoxical response. Okay? And if you want me to explain further what is all about this, paradoxical response during vasovagal reaction, here we go. So actually what happened is that you have a venous pooling. So the venous pulley pulls the blood. So what happened is that your ventricles will be depleted of cardiac output. Your blood pressure drop because your volume is less. And then your artery has baroreceptors. They are spies. They can tell you, oh, there's something going on. Okay? So with that, the baroreceptors will report to the brain, and the brain will start communicating, and they release increased catecholamines. And you increase the catecholamines, but your ventricles are depleted with volume. So now the ventricles will contract vigorously. And so the ventricle, they got also receptors, and they will also connect again. They report to the brain. And then anyway, they go to the wrong spot here. So they went to the vagal spot in the medulla. And what happened